Welcome, future medical professionals, to the deep dive. Today, we're embarking on a really crucial journey, tailor-made just for you, especially if you're a first-year med student ready to tackle, well, one of the big ones, the musculoskeletal system.
Foundational.
Exactly. And our mission today, it's not just throwing facts at you. It's about giving you a real playbook for how to learn this stuff
Yeah.
and actually retain it. We want to give you strategies to make those complex anatomy terms, genuinely stick.
What's fascinating here is that we'll be leaning on Dr. Hilary Manton's lecture on the MSK system. It's a fantastic starting point. Because remember, anatomy isn't just another subject. It's really the language of medicine. Nailing it early gives you the bedrock for, well, everything that comes after. Physiology, pathology, clinical practice, you name it. So this deep dive is about building that mental framework, right? Not just isolated facts.
Absolutely. And as you start your medical journey, I want you to keep a question in mind as we go. What's your current strategy for tackling this huge volume of new info? And honestly, how effective do you think it is? Hold on to that thought, because our first segment is basically a med student's secret weapon for learning. And hey, throughout this, let's maybe picture a hypothetical patient. Let's call her Sarah. Maybe a college athlete, complex wrist injury. We'll see how everything we discuss, the language, the bones, the joints, helps us understand what's going on with Sarah.
That idea makes it more concrete.
So, okay, before we even touch a bone or muscle model, Dr. Manton's lecture gives us this brilliant playbook for learning. Let's call it the anatomy learning playbook. It's basically got the do's and the don'ts. First up, the do's, what you should be doing. We can maybe think of this as a SMART approach.
Smart. I like that. What's the S?
S is for start small, master the big picture, which really boils down to little and often. Consistent, short study sessions, not cramming, definitely not cramming.
Right. Avoid the all-nighters if you can.
Exactly. Think of it like building muscle. You need regular, focused workouts, right? Not one massive lift that just wipes you out.
Good metaphor. Makes sense.
And starting with the big picture, that's like, imagine trying to navigate London without a tube map first. You need that overview, the blueprint, before you start worrying about every single side street. It helps you actually understand where things fit.
So get the overall framework before the minutia. Okay.
Then we have A for active recall and R for regular testing. This isn't just passively rereading notes. It's like actively digging that information out of your brain.
Forcing retrieval.
Yeah. Close the book, explain it out loud, draw it from memory, whatever works for you, and regular testing. Crucial. Testing yourself, testing each other. Dr. Manton mentions tools like flashcards. Ankai is a really popular one.
Oh, yeah. Ankai is huge for spaced repetition.
And Moodle quizzes. Complete anatomy quizzes. These aren't just busy work, they're feedback loops. They show you what you don't know yet.
That's a really critical point, actually.
Yeah.
For a first-year student facing this, just absolute flood of information, why do you think these DOs are so much more effective than the don'ts, like cramming? What's the real difference there?
That's a great question, and I think from my perspective anyway, it's about moving from just passively absorbing stuff to actively engaging with it. When you're doing active recall, you're literally forging stronger connections in your brain. You're making it work harder. So it remembers better. Passive reading, it just feels like you know it, but it often doesn't stick.
Precisely. And there's solid cognitive science behind that. Every time you successfully recall something, you strengthen that neural pathway. Makes it easier next time. Now, the flip side, the donuts. The traps to avoid. Our source highlights. Don't get bogged down in the tiny details too soon. Resist memorizing every little bump on a bone before you know what the bone does.
Right, context first.
Exactly. Don't just read it. Passive learning feels easy, but it's usually pretty ineffective for long-term retention. And maybe the biggest one, don't leave it to the last minute. Anatomy builds on itself. It's cumulative.
Oh, definitely. You can't understand shoulder movement if you don't know the scapula or the humerus.
Exactly. So understanding how to learn is, honestly, just as vital as what you learn. So think back to that question I posed earlier about your own learning strategy. Maybe you've got some new ideas now.
Yeah, hopefully. It really is a game changer when you figure out how you learn best. Okay, so we've got our learning strategy sorted, more or less. Now let's dive into the actual language of the MSK system. It's like learning the alphabet before you can read right, or setting up your GPS before you drive somewhere new. And this language, absolutely vital for understanding Sarah's wrist injury. We need precision.
Couldn't agree more.
So our universal starting point, our medical GPS origin, is the anatomical position. You have to picture this. Standing straight up, feet flat, toes forward, arms by your sides.
Palms facing forward.
Yes. Palms forward, gaze straight ahead. Everything is described relative to this position. It avoids so much confusion.
It's the standard reference,
Aye.
essential. From there, we get our directional terminology,
Yeah.
usually comes in pairs. Host, want to kick us off with a couple?
Sure. Let's do the basics. Superior, meaning towards the head, and inferior towards the feet. So like your nose is superior to your mouth. Simple enough.
Straightforward.
Then anterior or ventral, that's towards the front. Think belly side. And posterior or dorsal, that's towards the back, like a shark's dorsal fin.
Right. So your sternum, your breastbone, is anterior to your spine. And this precision is key. If Sarah says her wrist hurts on the front, that's vague. But if we say the pain is on the anterior aspect of the distal radius, boom, everyone knows exactly where that is.
Instantly clear. Okay, next pair. Medial, closer to the midline of the body, and lateral, further away from the midline. Imagine that line down your center. Your belly button is medial to your hips. Your thumb, in the anatomical position, is lateral to your pinky finger.
Good examples.
Yeah.
And crucial for limbs. Proximal and distal. Proximal means closer to where the limb attaches to the trunk. Distal is further away.
Right. So your shoulder is proximal to your elbow. Your fingers are distal to your wrist. Super important for describing injuries like Sarah's, where along the arm or leg is the problem.
Exactly. Then we've got superficial, closer to the surface, and deep, further inside. Your skin is superficial to your muscles. And finally, ipsilateral, same side of the body, and contralateral, opposite sides.
Ipsilateral, like if Sarah injured a nerve in her right arm and it affected muscles in the same right arm.
And contralateral, think stroke. A stroke on the right side of the brain often affects the left side of the body.
See, these terms seem abstract at first, but they become second nature because they're just so necessary for clear communication.
They really do. Precision is everything.
And speaking of precision, we also need laterality. Unilateral affecting one side, bilateral affecting both sides, like bilateral knee pain.
Simple but important distinctions.
Then, anatomical planes. These are ways we imagine slicing the body to describe locations. The sagittal plane divides the body into left and right portions. Think of slicing bread lengthwise.
Mid-sagittal is right down the middle. Parasagittal is off to the side.
Right. A coronal or frontal plane divides it into front, anterior, and back posterior parts. And a transverse or axial plane cuts across horizontally, dividing it into top superior and bottom inferior parts.
Like a CT scan slice.
Exactly. For Sarah's wrist, knowing these planes helps us visualize the injury in 3D. Where did the force come from? Which structures were hit from which direction?
Absolutely. It pinpoints the damage. Now, beyond static descriptions, we need the language of movement. Anatomical movements. Host, what are the big ones to start with?
Okay, the essentials. Flexion and extension, and then abduction and adduction. Flexion generally decreases the angle between parts, like bending your elbow or knee.
Bringing them closer together.
Yeah. Extension is the opposite, increasing the angle, straightening the joint. Now the A words, abduction, remember AB for away, is moving a limb away from the midline, like raising your arm sideways.
Taking it away.
And adduction ADD for adding back is moving it back towards the midline, adding it back to the body.
These four are your absolute bread and butter for describing joint movement, injury limitations, rehab exercises, everything.
Totally. Then there's rotation, movement around a long axis, like turning your head no.
Which can be medial or internal rotation, turning towards the midline, or lateral external rotation, turning away.
And specifically for the forearm, this is relevant for Sarah's wrist pronation and supination. Pronation turns the palm down or backwards. Supination turns it up or forwards.
Like holding a bowl of soup. That's the classic mnemonic for supination.
It works. And these movements, like trying to turn a key or a doorknob, could be really painful for Sarah. Mastering this vocab is, it's the foundation.
Couldn't agree more. It unlocks everything else in MSK.
Okay, language nailed down. Now, let's explore the first big component, the skeleton itself. Way more than just Halloween decor. The adult skeleton has 206 bones. You'll get to know that number.
Intimately.
But the real insight isn't just counting. It's understanding how the different regions work. Expert, what's the most fundamental division?
Right. So the skeleton is bilaterally symmetrical, left and right mirror images, basically. And we split it into two main parts. First, the axial skeleton. Think of your central ichthys. This includes the skull, the vertebral column, ribs, sternum, hyoid bone. Its main job, protection, guarding the important stuff.
Got it. Central core, protection. What's the other part?
The appendicular skeleton. This is all about motility, movement. It's everything else, your limbs, so arms and legs, and the girdles, the shoulder and pelvic girdles that attach them. Think of them as appendages hanging off the central axis. built for getting around.
Okay, so axial for protection, appendicular for movement. Makes sense. And what about the functions of bone itself? We can use the 5 S's plus H and L idea here.
Let's hear them.
Okay, first S, support. It's our rigid framework. Second, protection, like the skull protecting the brain, ribs protecting lungs and heart. Third, movement or leverage. Muscles attached to bones, and bones act as levers across joints.
Crucial for locomotion.
Fourth, storage of minerals, mostly calcium hydroxyapatite crystals. This gives bone its hardness, its resistance to compression.
The inorganic component, very important.
Yep. Then beyond the S's, we have H for hemipoiesis blood cell formation, happens in the red marrow, and L for lipid storage, that's the yellow marrow, energy reserve for emergencies.
So structural, protective, metabolic bones do a lot.
They really do. And crucially, they aren't just rock-hard minerals. There's an organic component too, mainly type I collagen. That collagen gives bone flexibility, resistance to tension or pulling forces.
Right. The inorganic part resists compression. The organic part resists tension.
Exactly. It's like reinforced concrete. The minerals are the cement, the collagen is the rebar. That balance is why bones can withstand different types of stress, and why fractures happen when that balance is overwhelmed, maybe like in Sarah's fall.
And that balance, that composition, directly influences the different types of bones we see. Bones are classified by shape, which usually relates to their job. We can use the FLS system for this.
FLS, okay, what's that stand for?
F is for flat bones, like in the skull or the scapula. Broad surfaces for protection or muscle attachment. I for irregular bones. Complex shapes, like vertebrae, lots of different functions.
Makes sense.
L for long bones, like the femur in your thigh or the radius and ulna in Sarah's forearm. Longer than they are wide, act as levers. S for short bones, cube-shaped, like the carpals in the wrist. Stability, some gliding movement, very relevant for Sarah.
Ah, okay, so Sarah's wrist has lots of short bones.
It does. And the final S is for sesamoid bones. These are bones that develop within a tendon. The biggest example is the patella, the kneecap. They can change the angle a muscle pulls, making it more efficient.
Wow, okay. FLSS flat, irregular, long, short, sesamoid. Shape dictates function. And sticking with long bones for a second, let's look at their structure. There's the main shaft, the diaphysis, then the ends, those are the epiphysis, plural epiphysis.
Right. Diaphysis is shaft, epiphysis ends.
And where they meet, that region is the metaphysis. Crucially, in kids and adolescents, like maybe our athlete, Sarah, there's the epiphyseal plate or growth plate in the metaphysis.
Kind of cartilage?
Yeah, where the bone grows longer. Once growth stops, it fuses and becomes the epiphyseal line. And it's a common injury spot in young athletes.
Absolutely. That growth plate is weaker than solid bone. You can think of a long bone like a tree again. Diaphysis is the trunk, epiphysis are the branches and roots, and the metaphysis with its growth plate is where the new growth rings form.
Nice analogy.
We also have the term apophysis. That's a normal bony outgrowth, usually where a tendon or ligament attaches,
Yeah.
like the bumps you can feel in your bones.
Okay. And internally?
Internally, bone has an outer cortex dense, compact bone. Looks whiter on x-rays. And an inner medulla, less dense, cancellous or spongy bone.
And that density difference is super practical, right? It's why we can see fractures on x-rays.
Exactly. The x-rays pass through the less dense medulla more easily than the cortex, so breaks in the cortex show up clearly. Vital for diagnosing Sarah's wrist.
Okay, so we've got the scaffolding, the bones, but they don't move on their own. That's where joints come in, the unsung heroes of flexibility. For Sarah to get her wrist moving again, her joints need to heal and function properly.
Definitely. So what is a joint, basically?
Simply put, it's where two or more skeletal elements, usually bones, meet or articulate. We can classify them in a couple of ways. First, by how much movement they allow.
Okay. What are the categories?
Three main ones. Synarthrosis, these are immovable joints. Think the sutures holding your skull bones together, no movement wanted there.
Right. Protection first.
Then ampuarthrosis, slightly movable joints, like the joints between the bodies of your vertebrae, cushioned by discs, allow a bit of flex.
A little give and take.
And finally, diarthrosis, these are freely movable joints, and this category mainly includes the synovial joints.
Ah, the synovial joints, the big players.
Exactly. Now, the other way to classify joints is by the type of tissue connecting the bones.
Also 3 types here.
Yep. Fibrous joints, connected by dense fibrous tissue, again, think skull sutures. Virtually no movement.
Cartilaginous joints, connected by cartilage, like those intervertebral discs again, or the pubic symphysis where the pelvic bones meet at the front, allow no or minimal movement.
And then the main event, synovial joints,
Mm.
connected by a joint capsule enclosing a cavity, like the knee, shoulder, hip, elbow, and Sarah's wrist. These allow a whole range of movements.
Right. Synovial joints are the most common type and the ones allowing most of our familiar movements. They are the rock stars, really. What is it about them, host, that allows such versatility? What are their key features?
Well, the big thing is that articular cavity, right? It's filled with synovial fluid. This fluid is like super lubricant. It nourishes the cartilage, absorbs shock, and drastically reduces friction.
Allows smooth gliding.
Exactly. Which lets synovial joints perform all sorts of actions. Flexion, extension, abduction, adduction, rotation, circumduction, gliding. Without that fluid and the smooth articular cartilage covering the bone ends, movement would be grinding, painful. Maybe like what Sarah is feeling now.
It's a very elegant system, and there are different types of synovial joints based on the shape of the articulating surfaces, which dictates the kind of movement allowed.
Right, like hinge joints, think elbow or the joints between your finger bones. They only allow movement in one plane, basically flexion and extension, like a door hinge.
Simple but effective.
Then ball and socket joints, like the shoulder and hip.
Yeah.
A rounded head fits into a cup-like socket, allows movement in multiple axes, flexion, extension, abduction, rotation, most mobile type.
But potentially less stable because of that mobility.
True. There's also condyloid joints, like the main wrist joint, actually, between the radius and the carpal bones, allows movement in two planes, flexion, extension, and abduction plus circumduction, but not really rotation. Relevant for Sarah.
Very relevant. What else?
We have pivot joints, where one bone rotates within a wing formed by another bone and maybe a ligament, like the joint that lets you turn your head, no? Atlantoaxial joint.
Allows rotation.
Saddle joints, where both surfaces are saddle-shaped, concave in one direction, convex in the other. The best example is the base of your thumb, allows opposition.
Is that opposable thumb?
And finally, plane joints, where flat or slightly curved surfaces glide or slide against each other, like between some carpal bones in the wrist or tarsal bones in the foot.
Lots of variety, each suited for its function. Now, all this moving is great, but joints also need stability. What keeps them from just falling apart?
Good question. It comes down to three main things. We can call it the MSL triad for stability.
MSL. Why?
M is for muscle tone. This is actually a major factor. Think about the rotator cuff muscles holding your shoulder joint together. If those muscles lose tone, dislocation becomes much easier.
Active stability, very important.
S is for the shape, size, and arrangement of the articular surfaces. How well do the bones fit together? Think of the deep socket of the hip joint, very stable compared to the relatively shallow shoulder joint.
Intrinsic bony stability.
And L is for ligaments. These are strong bands of collagen connecting bone to bone. They act like passive restraints, preventing excessive or unwanted movement.
Like strapping tape.
Exactly. But if you stress them too much, like in a bad sprain, maybe Sarah's wrist injury involves ligament damage they can stretch or tear, leading to instability.
So muscle tone, bone shape, and ligaments. The MSL triad.
Got it. And around these joints, we find other important structures too. We mentioned ligaments.
Bone to bone. Collagen. Support.
Then tendons. Also collagen, but they connect muscle to bone. They transmit the force generated by muscles to move the bones.
Like ropes connecting the muscle engine to the bone lever.
Perfect analogy. And bursae. These are little fluid-filled sacs lined with synovial membrane. They sit in places where tendons or muscles might rub against bone, acting as cushions to reduce friction.
Like little water balloons flattening out. Prevent wear and tear.
Exactly. This whole intricate setup around a joint, the nerves supplying it, the muscles moving it, the skin over it, brings us to Hilton's law.
Hilton's law always comes up.
It does. The sensory nerve supplying a joint also supplies the muscles moving the joint and the skin overlying the insertions of these muscles. Think Hilton's holistic connection. One nerve often pulls triple duty in an area.
Which makes clinical sense. Pain in a joint often radiates or is associated with muscle spasm or skin sensitivity changes in that region. It's all connected neurologically. If Sarah has wrist pain, the nerve involved might also affect her wrist muscles and skin sensation there.
Brilliant connection. Okay, framework. Joints. Now, the engines, what makes everything actually move. That's the power of skeletal muscle. If Sarah wants to get her wrist strength back, her muscles are absolutely key.
The movers and stabilizers.
Right, functions of skeletal muscle. Let's use MSHCP.
Okay, MSHCP.
Movement, obviously. Stability of joints we just mentioned. Muscle tone. Posture, holding us upright. Heat generation, shivering, is muscle contraction. And converting chemical energy into mechanical work.
The body's engines, for sure. How do they attack?
Well, for a muscle to move a joint, it has to attach to bones on both sides of that joint. We call these attachments the origin and the insertion.
Origin and insertion always trip students up initially.
It can. Generally, the origin is the attachment to the bone that stays relatively stable during the movement. It's usually more proximal. The insertion is the attachment to the bone that moves, usually more distal.
So when the muscle contracts,
It pulls the insertion towards the origin. That's what creates the movement at the joint.
right. Understanding how these muscles work together is vital for complex movements. But consider this fundamental point, host. Why can muscles only pull, not push?
Ah, great question. It's because muscle tissue is designed to contract, to shorten. It generates force by pulling its ends closer together. There's no biological mechanism for it to actively lengthen and push something away.
Exactly. That's why movements always involve pairs or groups of muscles working together. Some pulling one way, others controlling or reversing the movement.
Which leads nicely into some anatomical rules of thumb about muscles.
Lay them on us.
Okay. 1, muscles pull, they don't push. We just covered that. 2, if a muscle crosses a joint or more than one joint, it acts on each joint it crosses. Think biceps brachii crossing the shoulder and elbow.
Multi-joint muscles, important concept.
3, generally, if a nerve physically runs across or near a muscle, it innervates it. Proximity often equals function.
And 4, a nerve supplying a muscle often also supplies the overlying skin. Hilton's law again? See how it keeps popping up?
It really does tie things together. Now, muscles don't usually work alone. They work in teams.
Functional groups.
Yeah, we can use the FAAS system for this.
FAAS.
Okay, FAAS, what do we got?
Agonists are the prime movers, the main muscle doing the desired action, like the biceps flexing the elbow.
The main player. Antagonists oppose the agonist. They have the opposite action. Like the triceps extending the elbow opposes the biceps flexing it. They relax to allow the agonist's movement.
The opposition.
Synergists help the agonist. They might stabilize the joint or contribute to the same movement, making it smoother or stronger.
The helpers.
And fixators stabilize the origin of the agonist, so the agonist has a firm base to pull from, like muscles holding the scapula steady while the arm moves.
The stabilizers. So agonist, antagonist, synergist, fixator, FAAS.
Got it. Think of that team opening a heavy door analogy. Agonist pulls, synergists help pull, fixator holds the doorframe steady, antagonist is on the other side trying to close it.
Nice visual. And
Yeah.
muscles are often grouped together physically too, right? In compartments.
Exactly. Often limbs are divided into compartments by fixed sheets of connective tissue called deep fascia.
And there's a golden rule here. Let's call it NBC, nerve blood compartment function.
NBC, I like it.
Muscles within the same compartment usually share the same nerve supply, the same blood supply, and perform similar actions. Function. Part of the same compartment group.
That is incredibly useful for learning. If you know what compartment a muscle is in, you can often predict its nerve supply and action.
Absolutely. And it's clinically vital, too. Thinking about compartment syndrome, swelling within a closed fascial compartment can compress nerves and blood vessels. Understanding these groupings is key.
Especially relevant for limb injuries, like potentially Sarah's wrist, depending on the severity and swelling.
Could be.
Okay. Wow. So what does this all mean? We have covered a huge amount of ground today, from those crucial learning strategies right at the start,
Little and often active recall.
to the absolute necessity of the anatomical language, the functions and structure of bone, the amazing variety and stability of joints, and how muscles actually create movement.
Quite the journey through the MSK basics.
For you, listening as a first-year med student, really take that little and often approach it to heart. It's your secret weapon. And for our patient, Sarah, every single concept we touched on, the specific bones like the radius, the carpal bones, the ligaments, the synovial joint structure, the muscles moving her wrist, the nerve supplying it, it all plays a role in understanding her injury and her path to recovery.
Absolutely. This deep dive, it lays the groundwork. But the real learning, the deep understanding comes from applying it, constantly questioning. So here's a final thought for you to chew on. Think about Sarah's recovery journey. From the moment she presents with wrist pain, through diagnosis, maybe imaging like x-rays, treatment, physical therapy, how many different elements of today's discussion, specific directional terms, joint types, muscle actions, bone composition, Hilton's law, compartment principles, how many of those would a clinician need to actively consider to manage her case effectively and get her back to her sport? Keep exploring those connections. Link this foundational knowledge to the clinical scenarios you'll encounter. That's how you'll truly start to appreciate the incredible interconnected complexity of the human body.